Yeah, good morning. This is one of the latest sessions, which is about this mysterious thing called large language models, which some of you will have heard about. Maybe you understand a lot about what they are, but it's fairly new in the NHS space. So large language models, you probably come across something like ChatGPT, which we'd have seen. And the question is, well, how do things like that move across into the NHS, into the health service world? So Shailen has come to talk to us today. This is his particular interest area. Um, I'll let him get cracking on in a minute. If you've got, if you've got any questions or problems, you can put something in the chat. If you've got any questions, put them in the chat. Otherwise, please feel free to wave at me if you're stuck on anything. Apart from that, I think we'll crack on. So Shailen, shall I leave the floor to you?
Thanks. Thank you, Chris. I'll just share my screen, make sure that works again. Firstly, thanks for attending and showing interest. I was just saying to Chris earlier on, I wasn't sure how many people would be interested in this sort of thing, but it sounds like lots of people are, which is certainly very reassuring. Um, Thanks to Chris as well, specifically for giving me this opportunity to present to you and facilitating this. My name's Shailen, and I want to talk to you about large language models, why I think they're important, and my research ideas. And essentially, the reason for this is I plan to submit a proposal for a fellowship to NIHR, National Institute of Health Research. I've got a short presentation. I've kept it quite light, and I'm happy to be interrupted at any point. The main point of this presentation is really to draw on your thoughts, your ideas, your experiences, and see if I'm going down the right path, if that makes sense. So a little bit about who I am. Professionally, I'm a medical doctor. I specialize in public health and train as a GP. I work predominantly clinically at the Royal London Hospital in East London in their acute primary care setting. So that's things like the urgent treatment centre and the out of hours services. And the other half of my time, I'm based at the London School of Hygiene and Tropical Medicine as a early careers researcher. And I'm in a group called the AI in Global Health and Healthcare group, where our main interest is seeing if we can utilize these newer technologies in a clinically safe and acceptable manner. I've been a doctor since 2005, so what's that, 21 years now. So I've been quite clinically active for many, many years. And a few years ago, I started working for a digital startup, and that's kind of what sparked my interest in AI and some of the newer technologies that we're seeing in medicine. Alongside that, I've got a bit of a personal interest as well. These are just some pictures of East London where I live and my family. But my wife, who's in the picture you can see, she started losing her vision in 2014. And then by 2017, maybe 2018, I can't remember when exactly, but essentially she became significantly sight impaired, wasn't allowed to drive anymore, couldn't work. And we thought, sort of game over. What should we do? The doctor said there's nothing they can essentially do to improve her vision. There's no treatment options, and her vision will just gradually deteriorate over time. But remarkably, what's allowed her to keep a degree of independence, keep working, has been technology. So this ranges from simple things, on your computer where you can use very large text formats or get the computer to read what's being written on your document to sort of newer technologies, AI technologies, where she can point her phone at something which she doesn't quite see properly, and the phone using its intelligence will work out what she's looking at. Or even, she had a problem catching the bus because she couldn't see the number at the front of the bus. Whereas now she can use her phone, point it at the front of the bus, and the phone will tell her obviously the number of the bus, but also where the bus is going. So it's made a real big difference, a real beneficial difference in our own lives. And I'm quite eager to ensure that doctors are using technologies, especially in primary care, where a lot of technologies kind of get aimed towards secondary care and primary care. GPs, I feel, get a little bit neglected with the development of new technologies. The technology which I want to talk to you about are large language models. These are a type of artificial intelligence that seems to understand language in a deeper sense than what we've seen before. And I've got an example there of a few sentences. I'll give you a chance to read it, but essentially it's saying the patient has a cold, the patient feels cold, the consultant gave a cold response, the case has gone cold. The word cold appears in each of those sentences, but means something different in each of those sentences. And as other humans, you will understand what cold means within the context of those sentences. But traditional technologies wouldn't understand that. However, these large language models seem to understand language better than what we've seen before. It understands the word cold in the context of the rest of the sentence, whereas normal technology would be quite limited in the understanding of those words. And large language models can also generate new words, generate new text, new information, new sentences. Again, this is something which we've not really seen before. Now, how they work. So firstly, I'm not a computer scientist, and I don't really have a deep understanding of large language models. But essentially, from what I have understood is large language models have been trained on what people talk about, lots and lots of data. So scraping the internet, looking at lots of books. And so you've got a lot of textual language data there. And then this data is chopped up into little words or tokens, which is fed into the brain of the large language model, which is what people talk about these neural networks, which is the brain. And this brain learns the patterns in the words. So it learns sequences of words and what words follow other words. And this starts to allow it to predict the next word in a sentence. Now, what most people are familiar with is something called ChatGPT. This is a type of large language models. ChatGPT is just one of the companies, but there are other companies. I think ChatGPT is probably the most famous example of a large language model. And I suspect, and I'll probably ask you guys later, how many people have used a large language model such as ChatGPT. And there's a few things that make this technology, I think, special or worth thinking about. So firstly, it's the quality of the interaction. It's very human-like. You would be able to have a conversation with ChatGPT, and it wouldn't be obvious to you, I don't think, that this is a computer, that this is technology, that this isn't a real person behind the words telling it what to say. Secondly, it's the range and types of things it can do quite competently. So, for example, my father was using ChatGPT very recently, looking at inheritance tax and working out the options for inheritance tax, things which you would have, spoken to an accountant or a financial advisor who would have charged you, probably a high rate. But you can turn to ChatGPT and not that I'm recommending you do this, but the information it gives is remarkably good, and it seems to be getting better. And obviously, I can't talk about the financial information it's giving, but I know in a clinical setting, when I ask it a clinical question, it's giving quite reasonable answers. Compared to a few years ago, where I'd give it a clinical question and you'd be a little bit skeptical about its response. Now, if I give it a clinical question, it gives quite a competent response. So it's a sheer variety of things you can ask it, and it gives fairly reasonable answers, and that's unusual. And finally, the other thing which I think is worth thinking about is it's what we call non-deterministic, and by that I mean you get different answers for the same questions. It doesn't have a fixed response. And that's quite unusual in technology because usually what we like about technology is, we like it because it's predictable. You press this button, it will do this. So technology which is slightly unpredictable would usually not be something that we're comfortable with or not used to. But LLMs are non-predictable. They vary based on your input. So the same input, so writing the same thing can give a different answer. Now, what's this got to do with medicine, essentially? What's my interest in it? So doctors are using them. So doctors are using things like ChatGPT, Copilot. They're using these LLMs. And we have survey data already reported in the literature, which suggests nearly half of doctors are using them. And that's quite an increase. So in the same surveys been repeated now 3 times. So in 2024, it was sort of like 10, 15%. And then it doubled to 30%. And now 2026 data, which hasn't been published, suggests almost half of doctors are using these chatbot type large language models. Um, what are they using them for is probably the next question. And we have some data on that, again, from the surveys. And it's a whole range of things from helping them to write patients' letters, interpreting blood results, considering differential diagnosis, looking up guidance. Um, some of the ways they're using it are with defined tools. So the things like AI scribes, which you may have come across with your GP already, these are these tools which are listening to your conversation between the doctor and the patient, and it's transcribing that information, then it's summarizing it. So essentially, the doctor doesn't need to write his medical notes. It's already summarized by the large language model in the scribe to do so. Now, these are hard to understand sometimes how and when doctors are using them exactly. So I guess we know from the survey data that doctors are using it, and I know from my own experience walking around the hospital, I know junior doctors are using it, I know consultants are using it, I know GPs are using it. They're probably not using it officially. So ChatGPT isn't a medical tool. It's not licensed for medical use. However, it's being used. It's being used informally and it's being used, and there's widespread use from what I can see. Now that's of a concern. Um, it's of a concern because these aren't, like I said, medical devices. There's no real governance about how they're using it. We don't really know what data they're putting in when they're using it, whether they're sharing sort of personal identifiable information. I think it's unlikely that doctors would be sharing personal identifiable information, but I can't be sure. We don't really know what doctors are doing with that output as well. So, if you ask it a question and it suggests an answer, how are doctors really thinking about that answer? What are they double checking the answer, cross checking it elsewhere? We don't really know. And then we don't really know what happens when a doctor's pushed for time. So in my practice where I work, when you've got time, which is, I must admit, unusual, but when you've got more time, you can double check things. So you can speak to colleagues, you have other people or other things you can turn to. When you don't have time, you're more likely to default to a gut reaction, to a gut feeling. So my worry is that doctors, especially junior doctors, when they're pushed for time, they're not questioning what these LLMs are outputting. They're just accepting it as being correct. And then I don't really know whether doctors are really talking to patients and explaining that they're using a large language model to help them in their diagnosis, help them in their management, or whatever aspect they're doing. And I don't really know what patients want to know as well. But technology is always used in the background, whether we're interpreting a scan, um, calculating a risk score. There's always technology going on in the background. But how much do patients want to know about this particular use of this technology? Are they comfortable with doctors using the technology? Do they want to be told when it's used and how it's being used? And do they want to know what the output is? If a doctor's using it to help diagnose a complex patient and it comes out with a diagnosis which the doctor disagrees with, do they want to be told, this is a diagnosis a large language model came out with, which may later on be found to be correct, but the consultant thought it was wrong. So there's loads of questions, and I must admit it's quite hard to know where to begin because this is quite a new technology. We don't really have much in the way of guidance. As you probably know, guidance always lags behind real world use. And I'm more interested in capturing and understanding how people are using it firstly. I think that's probably a good starting point to understand how doctors are using it. And I'll just quickly show you sort of my proposal. These are my rough thoughts. But basically, I think by speaking to doctors and in my setting, be speaking to GPs, and it would have to be one-to-one interviews. And I would try and understand how they're using LLMs, what specific tasks, what data are they sharing, how they're interpreting the output, what they're checking, what they're sharing with patients. And then I feel like there's a piece of work where we need to understand what the public and the patients feel about the acceptable uses of of LLMs. And there might be some cases which people think is very acceptable, some cases where people think, no, this is a completely unacceptable use and it shouldn't be used like this. And whether patients want the output shared with them or they don't, whether it will just complicate matters. And then finally, I think there's probably some experiments which I can do where I can test the LLM and see how accurate it is, perhaps for the uses that GPs are describing, and examining things like bias, whether if I put in one input but change the age, does it dramatically change the output of the large language model? Is it biased by age or any characteristic? Um, I think Yeah, I think that's all I kind of want to say. I hope that's not been too quick or superficial. I hopefully that's giving you a rough idea of what large language models are. Um, there's lots of questions, but I think probably the first point to start would be if anyone's experienced using things like ChatGPT themselves. So there's increasing evidence that lots of people, rather than Googling their symptoms now, are turning to ChatGPT. So that's probably a good starting point to initiate a conversation if anyone wants to volunteer their experiences.
We are at time. I just got one request. Shailen, you've been asked if you could just recap on your fellowship application. I don't know if you can go back a couple of slides. There's one thing that you were interested in. If anybody's interested in keeping in touch with Shailen in his work, we can, if you drop me a note, you've all got my email, I'll put you in touch directly and then you can take it from there if that's helpful to you. Um,
Yes, yeah. Thanks, Chris. Yeah, and yeah, please do share my email. And please feel free to contact me directly. So a very quick recap. So my gut feeling is I need to understand more what doctors are using it for. Like I said, we only have survey data about sort of how many people are using it, really understanding how they're using it, when they're using it, what information. And then my other gut feeling is we need to speak to people about these specific use cases because I feel like they're a bit like what Rashmi is saying. There's probably some cases where yes, you can use it, but you shouldn't be subservient to it. And so maybe if you use it like this, then yes, patients, the public are broadly happy. So I feel like I need to speak to people to understand what that looks like. And then the other thing which is about testing the LLM. So a lot of the experiments which have done on diagnostic accuracy, things like that, or bias, are based in America, and it doesn't quite equip well to the UK standards. You know how we have a 2 week wait pathway? Do these LLMs understand the 2 week wait pathway? Will it understand how primary care works in the UK, and rather than just spilling out healthcare information, which is applicable to the US. So I think there's some kind of experiments, which would be simple desktop experiments, vignettes, which you could just put into the LLM and see what kind of output you're getting. But in a nutshell, that's broadly what I'm thinking. But yeah, feel free to, to disagree or suggest alternative directions.
Shailen, thanks ever so much. That was a fascinating just over an hour. I think you crammed a heck of a lot into there and people really engaged. Just to note for everybody who's taking the time to put things in the chat, I'm going to be sending all that to Shailen. If anybody
Thank
wants a
you.
copy of the chat, by the way, um, you could email me. I doubt anybody would have a problem with sharing it, but if you did want it, just let me know and I can send you that as well. But just to say thank you so much for your time, everybody. Fascinating conversation, and I think clearly we're just at the start of the new world of LLMs. So thank you. Have a lovely weekend, and